Welcome back to the Rad-On Smart Review CNS Cancer series.
Glad to be here.
Today, we're really getting into some important nuances in episode 4 of our high-grade glioma series. We're kind of moving past the standard Stupp-eligible patient that, everyone learns first.
Exactly. We're tackling the special cases, the ones you actually see a lot in clinic,
Yeah.
focusing on elderly patients, how we handle recurrence, which is always tough, and the role of tumor-treating fields.
Right, because we've all, worked hard to master that standard step protocol for glioblastoma. It's foundational.
Absolutely. It's the cornerstone. But the reality is many patients just don't fit that mold, do they? They're older. Maybe their KPS-Karnofsky performance status is lower, meaning they're less functional.
Or they face recurrence. That's a big one.
A really big one. So our mission today really is to build a practical framework. How do you approach these challenging scenarios? Older folks, frail patients, recurrent disease. We want you to feel confident tailoring the treatment.
Yeah, it's about adding tools to your toolkit, isn't it? Because that standard approach, the 6 weeks of chemo-RT, it works wonders for the right patient, but it's just not always suitable.
Or even possible.
Precisely. You see these patients constantly older, maybe at KPS of 60 or 70, or the disease has unfortunately come back after initial treatment. These situations, they really demand more than just following a flowchart. You need a deeper understanding of the evidence.
And the clinical judgment to apply it.
Exactly. It's judgment. So to make this really practical, let's use a couple of typical cases you'll definitely encounter.
Good idea.
Okay, first, imagine an 82-year-old woman. Let's call her Mrs. Thompson. She comes in after a fall, gets an MRI.
Standard workup.
Standard workup, yep. And it shows a ring-enhancing mass. Left temporal lobe. Clinically, she's frail. Her KPS is 60.
So requires considerable assistance, but not completely dependent.
That's right. Needs help with daily activities. Biopsy confirms glioblastoma, and importantly, it's IDH wild type.
Okay, so primary GBM, typically more aggressive. Typically.
Mm-hmm.
Now, looking at her 82 KPS 60, she's clearly not a candidate for that intense 6-week Stupp-eligible protocol.
Right. No way. That'd be too much.
Way too much. So the question for you, the clinician facing Mrs. Thompson, is, what are her real options? What can we actually offer her that makes sense?
That's a perfect example of the dilemma. You really feel the weight of that decision. Okay, what's the second case?
Second case, let's revisit someone maybe we talked about before, hypothetically. Mr. Chen, 64 years old. He had a great initial run GTR, gross total restoration, followed by the full step protocol.
And did well?
Did really well, yeah. 18 months. That's a good outcome for GBM. But his latest surveillance MRI, it shows a new enhancing lesion, about 2 centimeters, right at the edge of his old resection cavity.
Classic recurrence pattern.
Textbook recurrence. So for Mr. Chen, who responded well initially, how do we approach this? How do we manage recurrent GBM?
Right. 2 very different, very common challenges.
And these 2 cases, Mrs. Thompson and Mr. Chen, they perfectly set the stage. They show why we need evidence and thinking that goes beyond just the original Stupp trial.
It's about individualizing care, isn't it? Using guidelines, sure, but really tailoring it based on the patient, their health, their life, what they want.
Absolutely. Clinical judgment is huge. It's not just memorizing protocols. It's understanding why we might deviate, why it's sometimes necessary.
So let's start with that first scenario, managing GBM in older or frail patients. What's the core philosophy here? You mentioned balancing efficacy and quality of life.
That's the heart of it. Efficacy versus quality of life. Why is the standard 6-week chemo-RT, the daily radiation with TMZ, so tough for this group?
I mean, it sounds grueling even for younger patients.
It is grueling. 6 weeks, daily visits, concurrent chemo, then more chemo. It's a significant physiological stress for someone older or frail like Mrs. Thompson.
They might not even live long enough to see the full benefit.
That's the harsh reality. They might gain a few months of survival, maybe, if they tolerate it. But they will definitely experience the toxicity, the fatigue, the nausea, the myelosuppression, the potential cognitive effects.
Which could just wipe out any quality of life they have left.
Exactly. It can make their remaining time miserable, often without a proportionate survival gain. This is why KPS is so critical, and why molecular markers like MGMT methylation become really important guides. We're often trading potential quantity for guaranteed quality.
That quality versus quantity distinction is just vital here, adding good days, not just any days. So how do we make this practical? Is there a KPS-based framework we can use?
Yes, absolutely. We can sort of stratify patients based on KPS to guide the intensity of treatment. Let's break it down.
Mm.
First, consider the fit elderly.
Okay. Who fits into that category?
These are generally patients 65 and older, but crucially, they still have a good KPS 70 or higher. They're mostly independent, getting around okay.
Right. Still active to a degree.
Exactly. For this specific group, the key trial, the one that really shaped our approach, is the Perry trial.
Ah, yes, Perry. That was a big one. Over 500 patients, right?
Yeah.
65 plus.
That's the one. A really important Canadian and European study. They randomized these fit elderly patients, KPS 70 or more, to get either short course hypofractionated radiation alone.
40 gray in 15 fractions over 3 weeks.
Yep, 40 and 15. Either that alone or the same 40 and 15 with concurrent and adjuvant TMZ, just like Stupp, but with the shorter radiation.
And what did Perry find? What was the key takeaway?
The results were pretty clear-cut. Adding the TMZ to the shorter radiation course significantly improved median overall survival. It went from about 7.6 months with radiation alone up to 9.3 months with the chemo-RT combo.
Okay, nearly a 2-month improvement in median survival. That's meaningful in GBM.
It is meaningful. And it also improved progression-free survival, PFS. Went from about 3.9 months to 5.3 months. So patients lived longer and lived longer without the disease progressing.
And critically, it was with a 3-rent radiation course, not 6.
Exactly. So you get a clear survival benefit, but with a significantly less burdensome treatment course compared to the full STIP protocol. That balance is why 40 and 15 plus TMZ became the evidence-based standard for these fit elderly patients.
That makes perfect sense. A really valuable option. Okay, so that's the fit elderly. What about the next group? The frail patients, maybe KPS 50 to 60, like our Mrs. Thompson case.
Right. For this group, the calculation changes significantly. Combined modality therapy, doing radiation and chemo together, is almost certainly too toxic.
Just too much burden for them.
Way too much burden. The side effects would likely outweigh any small survival gain, so we pivot. We go to single modality therapy.
Just radiation or just chemo?
Exactly.
Yeah.
And the critical decision point here, the thing that really guides the choice between those two, is that biomarker we mentioned, MGMT promoter methylation status.
6-methylguanine DNA methyltransferase. Always a mouthful.
It is, but it's so important here. MGMT status is the key. And the evidence guiding us comes primarily from 2 big trials. The NOA-08 trial from Germany and the Nordic trial.
Okay, so how do those trials and the MGMT status give us an algorithm for someone like Mrs. Thompson?
It's actually quite elegant based on those trials. If the tumor is MGMT methylated...
Meaning it's potentially more sensitive to TMZ.
Correct. If it's methylated, you offer TMZ monotherapy, just the chemotherapy pills. The NOA-08 trial, for example, showed that for these methylated patients, TMZ alone nearly doubled event-free survival compared to radiation alone. It was something like 8.4 months versus 4.6 months. A huge difference.
Wow, okay. So methylated means TMZ alone is clearly better.
Clearly better. Now, if the tumor is MGMT unmethylated...
Meaning less likely to respond to TMZ?
Right. And you offer hypofractionated radiation alone. The same trials showed that radiation was superior to TMZ in that specific unmethylated setting. So MGMT status basically tells you methylated gets TMZ, unmethylated gets radiation, because combining them is too toxic for this frail group.
That's a really clear biomarker-driven pathway. Very helpful. Now, for those unmethylated patients getting radiation alone, what about the fractionation? You mentioned 40 and 15. Are there shorter options?
Yes, and this is really important for practicality and quality of life. The Rome trial, which was combined with an IAEA trial, looked at this specifically in frail patients.
What did Rome show?
It gave us fantastic flexibility. It found no significant difference in survival between the 3-week course, 40 gray in 15 fractions, and a much, much shorter 1-week course, 25 gray in 5 fractions.
25 and 5, just 1 week of treatment.
Exactly. Think about that for Mrs. Thompson. 82, frail, KPS 60, poor prognosis likely with unmethylated GBM, reducing her hospital visits from 15 down to 5. It was a huge improvement in convenience, less travel, less burden on her and her family.
Absolutely. Massive difference in logistics and just hassle.
Right. And you're delivering a meaningful palliative benefit without compromising survival compared to the longer course. It's about making the treatment as humane and convenient as possible. That 25 and 5 regimen is an excellent option for these frail, unmethylated patients.
That's incredibly valuable information. Maximizing convenience is so key. Okay, now what about the patients at the lowest end of the performance spectrum, KPS less than 50?
Yeah, this is a really difficult situation. For patients with a KPS below 50, the focus shifts dramatically. It moves away from active anti-cancer treatment almost entirely,
Towards palliative care.
unequivocally towards palliative care and best supportive care. The key evidence here comes from the Quartz trial.
What did Quartz tell us?
Quartz essentially confirmed what clinicians suspected. For a GBM patient with such a low KPS, the burden, the toxicity, the stress of any active treatment, radiation or chemo, is likely to outweigh any tiny potential benefit. The morbidity is just too high.
So active treatment might actually do more harm than good.
In these cases, yes. Our focus has to be on managing symptoms, headache, seizures, weakness, ensuring comfort, maintaining dignity, supporting the patient and family. Best supportive care is the most appropriate and compassionate approach. It's a hard conversation, but necessary.
A very important point about knowing the limits of our interventions. Okay, let's pivot now to our second main challenge. Managing recurrent glioblastoma. Mr. Chen's situation. This is universally tough.
It really is. Recurrence is formidable. And the first thing we and the patient need to understand is that no treatment at this stage is curative.
The goals have to shift.
Completely. We're aiming to palliate symptoms, try to prolong quality time, and preserve neurological function for as long as we reasonably can.
And what's the first thing you should think about?
Always, always, always. Is there a clinical trial available? Participation in a trial should be the preferred option, if possible. That's where progress happens, and it gives patients access to potentially novel therapies.
Good point. Okay, if a trial isn't an option, and you're considering re-radiation hitting the area again with radiation, who's a good candidate for that? It sounds risky.
It does carry risks, absolutely. You're radiating tissue that's already seen a significant dose. So patient selection is key. The best candidates usually have a good KPS still, maybe 70 or higher.
Still relatively functional.
Right. And importantly, they've had a reasonable time interval since their first course of radiation.
What counts as reasonable? 6 months? A year?
Generally, we think at least 6 months and ideally longer, like a year or more. A longer interval suggests the tumor was initially controlled well, maybe it's slower growing, and the patient might tolerate and respond better to more local therapy. If someone recurs really quickly or their KPS is plummeting, re-irradiation is probably not a good idea.
Okay, that makes sense. And the main evidence guiding re-irradiation in recurrent GBM comes from RTO 1205, right?
Yes, RTOG 1205 is the landmark trial here. Really important study. It took patients with recurrent GBM and randomized them. One group got bevacizumab alone, that's Avastin.
Which was already used for recurrence.
Exactly. Bevacizumab alone versus bevacizumab plus re-irradiation. The re-irradiation dose was 35 gray in 10 fractions over 2 weeks.
Okay, so Bev versus Bev plus RT. What was the primary endpoint? Survival.
Yes, overall survival was the primary endpoint. And unfortunately, the trial did not meet it.
No OS benefit.
No significant difference in overall survival. Median OS in both arms was pretty similar, around 10 months or so. Adding re-irradiation didn't make patients live longer overall in the recurrent setting.
Huh. Okay, so no overall survival benefit, but I feel like there was something else significant found in 1205.
Ah, yes. And this is the clinically crucial part. While OS wasn't improved, re-irradiation significantly improved progression-free survival, PFS.
Okay, so it delayed the tumor from growing back again?
By a significant margin. The 6-month PFS rate was nearly doubled. It went from about 29% with Bev alone to 54% with Bev plus re-irradiation.
Wow, 29 to 54% at 6 months. That's a big difference.
It's a huge difference. Think about what that means for the patient. Doesn't mean they live longer overall, necessarily, but means they live longer without the tumor progressing. That translates to more time with stable or improved neurological function, better symptom control. It's a really meaningful palliative benefit.
Buying good quality time, essentially.
Exactly. It buys time, often good quality time, before the next progression. That's incredibly valuable for these patients.
That's a great way to frame it. And just to clarify the role of bevacizumab, Bev itself, what you mentioned it was in both arms of 1205. Has it ever shown an OS benefit in GBM?
That's a key point to hammer home, no. Despite improving PFS and often helping with symptoms like swelling, bevacizumab has not been shown to improve overall survival in GBM. Not in the upfront setting that was shown in the Avalio and RTOG 082 trials,
Right.
and not in the recurrent setting either, based on the EORTC 26101 trial. It helps symptomatically, delays progression, but doesn't extend overall life. Important for managing expectations.
Very important distinction. Okay, let's switch gears now to something that has shown a survival benefit and generated a lot of buzz. Tumor-treating fields or TT fields?
Ah, yes. TT fields. Definitely one of the biggest advances in GBM treatment in recent years.
What exactly is it? It sounds kind of sci-fi. How does it work?
It does sound a bit futuristic, doesn't it? It's a completely different approach.
Yeah.
Basically, patients wear these transducer arrays, like specialized patches, on their shaved scalp for most of the day.
Okay. And these patches do what?
They generate low-intensity, intermediate-frequency, alternating electric fields, usually around 200 kilohertz. These fields pass through the brain non-invasively.
And the electric fields target the tumor.
They preferentially affect rapidly dividing cells, like cancer cells. The key is that these specific electric fields disrupt mitosis, the process of cell division. They interfere with the formation and function of the mitotic spindle, that crucial structure that pulls chromosomes apart when a cell divides.
So it messes up cell division in the cancer cells.
Exactly. It causes abnormal chromosome segregation. The cell gets stuck in mitosis and eventually undergoes programmed cell death, apoptosis. And a big advantage is that it's a physical modality, so its toxicities don't really overlap with chemo.
Fascinating mechanism. And the trial that really put this on the map was EF-14.
EF-14, yes. That was the pivotal phase 3 trial, huge impact. They took newly diagnosed GBM patients after they had finished their initial standard chemoradiation, the Stupp protocol part.
Okay, so during the maintenance TMZ phase.
Precisely. They randomized them to get either standard maintenance TMZ alone or maintenance TMZ plus TT fields. The patients had to wear the device for at least 18 hours a day.
And the results were?
Striking. Really striking. A clear, significant survival benefit, the kind of benefit we hadn't seen since Stupp itself.
What were the numbers? How much did survival improve?
Median overall survival jumped from 16.0 months in the TMZ alone group to 20.9 months in the group that got TMZ plus TT fields.
Almost 5 months improvement in median OS. That's huge for GBM.
It's massive. But maybe even more impressive was the long-term survival. The 5-year survival rate. It went from just 5% with TMZ alone to 13% with the addition of TT fields.
Wow. More than doubled the 5-year survival rate.
More than doubled, going from 5 to 13% at 5 years for GBM. That's monumental. And that magnitude of benefit is exactly why TT fields received an NCCN Category 1 recommendation. It became part of the standard of care for newly diagnosed GBM during maintenance.
That really underscores the impact, but practically speaking, wearing a device for 18 hours a day, that sounds challenging. Are there downsides or controversies?
Oh, absolutely. It's not a simple pill. Compliance is a huge factor. Patients have to be really motivated and dedicated to wear it that much. There's managing the wires, changing the arrays, the cosmetic aspect of a shaved head, and the device. It's a big lifestyle adjustment.
I can imagine. What about side effects?
The main side effect is skin toxicity under the arrays, redness, irritation, sometimes itching, or even breakdown. It requires diligent skin care, rotating the array positions.
Okay. Any other considerations?
Well, there's the cost and logistics, although insurance coverage is generally pretty good now. And, ongoing research is looking at using it in recurrent disease, combining it with other therapies, maybe optimizing the fields. It's an evolving area. But the EF-14 data for newly diagnosed is undeniable.
A truly transformative therapy despite the practical challenges. Okay, this has been a fantastic discussion covering these complex areas. Let's try to crystallize the main takeaways, maybe some clinical pearls.
Sounds good. Let's lock these in. Pearl number 1. For your fit elderly GBM patients older than 65, KPS 70 plus the standard is hypofractionated chemo-RT, 40 gray and 15 fractions with concurrent and adjuvant TMZ.
Yeah.
Remember, the Perry trial showed this improves median OS to 9.3 months versus 7.6 for RT alone.
Okay, pearl number 2. For the frail elderly with MGMT methylated GBM, think single agent. TMZ monotherapy is preferred. NOAZ-08 showed an improved event-free survival significantly compared to RT 8.4 versus 4.6 months.
Pearl number 3. For those same frail elderly patients, but with MGMT unmethylated GDM, TMZ won't work as well. So, hypofractionated RT alone is superior. And remember, Rho-MEAEA, you could use a convenient 25 gray and 5 fractions course.
Got it. Pearl number 4, tumor-treating fields. Adding TT fields to maintenance TMZ for newly diagnosed GBM gives that big survival boost, median OS up from 16 to almost 21 months based on EF-14, NCCN Category 1.
Pearl number 5, recurrent GBM. Re-irradiation, typically 35 gray and 10 fractions, doesn't improve overall survival, which stays around 10 months. But RTD-1205 showed it does significantly improve progression-free survival, nearly doubling the 6-month rate. Buys good quality time.
Excellent. And the final pearl, number 6, bevacizumab. Just remember, despite improving PFS, sometimes it has not shown an overall survival benefit in upfront GBM. Evalio RTG0825, or recurrent GBM, EORTC2 non-C6101. Manage expectations.
Exactly. Those cover the key points from today's discussion, I think.
Perfect. Now let's put this into action. Time for our board blitz segment. Ready for some cases?
Let's do it. Always good to test the application.
All right, case 1. You have an 80-year-old woman, KPS is 60. She just got diagnosed with an MGMT unmethylated glioblastoma from a biopsy. She's clearly not fit for aggressive chemo-RT. What's the most appropriate management? A, standard 60 gray chemo-RT post-up. B, TMZ monotherapy. C, hypofractionated radiation to 25 gray in 5 fractions. Or D, best supportive care only.
Okay, 80 years old, KPS 60, MGMT unmethylated. Let's think through the options. A, Stupp protocol. Definitely not. KPS 60 is too frail.
Agreed. Too toxic.
PNG monotherapy. No, because her tumor is MGMT unmethylated. We know from NOA-08 and Nordic that RT is better than TMZ for unmethylated tumors in this setting.
Right, TMZ likely wouldn't work well.
The best supportive care only. Probably not yet. KPS 60, while frail, often still warrants some active palliative treatment. We reserve BSC usually for KPS less than 50.
So that leaves
C. Hypofractionated radiation to 25 gray in 5 fractions. This fits perfectly. She's frail, MGMT unmethylated, so RT is indicated over TMZ. And the ROE-EA trial showed 25 and 5 is non-inferior to 40 and 15 for survival in frail patients, but way more convenient. It's the ideal palliative RT regimen here.
excellent reasoning. Hits all the key points. Frailty, MGMT status, convenience. Okay, case 2. 69-year-old man, but this time KPS is 90. Very fit. He's had a GTR of a GBM. You're counseling him on adjuvant therapy. Which regimen has the highest level of evidence for improving OS in this specific population? A, 60G and 30 fractions with chemo. Stupp. B, 40G and 15 fractions with chemo. C, 40G and 15 fractions alone. Or D, TT Fields alone.
Okay, 69 years old, KPS 90, so fits the fit elderly category. We need the highest level of evidence for this age group. A, Stupp, 60G plus chemo. That's the standard for younger patients, but is it the best evidence for age 69?
Maybe not the most specific evidence.
Exactly. C, 40G on and 15 alone. Perry showed adding chemo was better. D, TT Fields alone. No, that's added to maintenance chemo, not used alone up front. That leaves B, 40 gene and 15 fractions with concurrent and adjuvant TMZ. This is the regimen tested specifically in patients 65 and older in the Perry trial.
Ah, so Perry's the highest level of evidence for his age group.
Precisely. Perry directly compared 40 and 15 plus TMZ in the over 65s and showed the combined treatment improves survival. So while Stupp is the general standard for someone 65 or older, the Perry regimen, 40 and 15 plus chemo, has the most direct high-level evidence supporting it. Answer is B.
Fantastic distinction. Age matters for the specific evidence base. Okay, final board blitz case. Let's go back to Mr. Chen. 64 years old, recurrence at 18 months after finishing Stupp. KPS is still good at 90. Which statement about re-irradiation is most accurate? A, it's expected to give significant OS benefit. B, it's contraindicated because he already had 60 GI. C, it's likely to improve PFS but not OS. Or D, it should only be offered with concurrent BEV.
Okay, recurrent GBM, good KPS, good interval, 18 months, thinking about re-irradiation. A, significant OS benefit. No. RTOG 1205 showed no OS benefit, so A is out.
Right.
B, contraindicated due to prior 60G. No, that's not an absolute contraindication. Re-irradiation is definitely an option for selected patients like Mr. Chen with good KPS and interval, so B is out.
Okay.
D, only offered with concurrent BEV. No. While 1205 used BEV, re-irradiation can be considered without it or potentially with other systemic agents in trials, so D is too restrictive. Leaving C. It's likely to improve progression-free survival, but not overall survival. That perfectly summarizes the main finding of RTG 1205. Re-irradiation offers a meaningful palliative benefit by delaying progression, even if it doesn't extend overall lifespan. C is the most accurate statement.
Perfect. Those cases really help solidify the application of all that trial data.
Yeah, it forces you to integrate the different pieces of evidence for specific patient scenarios. Very useful.
Well, today we've really, I think, broadened our GBM toolkit. We moved past that standard Stupp framework to figure out how to tailor treatments for, some of the most challenging patients we see, that elderly, the frail, those with recurrence. And we touched on TT Fields too.
Absolutely. And the recurring theme, the real key takeaway, is individualization. It's not one size fits all. You have to weigh the patient's age, their KPS, those crucial molecular markers like MGMT, and always their goals of care, what matters most to them.
Optimizing quality of life, function, especially when cure isn't on the table.
Exactly right.
So, looking ahead, our next session is going to be really practical. We're doing our high-grade glioma treatment planning workshop. We'll
Ah,
pull together everything on GBM and anaplastic glioma volumes, contours, and crucially, the dose constraints you absolutely need to know for safe treatment delivery.
that's essential. Knowing the evidence is one thing, but safely planning and delivering the radiation is where it all comes together. That'll be a critical session.
Definitely. So you can get the show notes for today and access complete practice oral boards over at radonsmartlearn.com. That's RADONCSMARTLEARN.com, pronounced radonsmartlearn.com. And be sure to subscribe to Radon Smart Review so you don't miss that planning workshop.
Thanks for joining us.
Yeah, thanks everyone for tuning in.